sometimes we need a grown-up in the room just to say, this is not sexy, it's not the hot story, but it remains important, it remains common, it remains crucial to most families at some level in Canada. And that's, that half of us will get cancer in our lifetime, nearly a quarter of us will die of cancer, about 80 to 85,000 people a year die of cancer, a quarter of those are lung cancer. And when we talk about progress, and I talked earlier about, my ChatGPT example of lung cancer having the biggest improvement. So 5-year survivals in lung cancer, great. They've gone from 10% 15 years ago to 22, 23%. They've more than doubled. It's been fantastic advance. But we're wrong-headed if we think that's success, because really what that means is 78% of people with lung cancer are not surviving 5 years.
Hey everyone, I'm Costas.
Hi, I'm Lester, and welcome to another episode of What's with RWE. And today we have another fantastic guest with us today, Dr. Paul Wheatley-Price. Paul is an oncologist at the Ottawa Hospital. He is also the former president of Lung Cancer Canada, and he is, from what I've heard, a legendary singer as well from some of the conferences I've attended. So how are you doing, Paul?
What a great introduction. Infamous singer.
Yes. I think it's the British roots.
I'm well, thank you. Yeah, I did a bit of a takeoff at a conference of a John Denver song just to try and illustrate a point. But yeah, I don't think anyone's going to be giving me any Grammys anytime soon.
Next time you can serenade us with one of your original songs. But the reason why we brought on Paul today is not just because he's a legendary oncologist, just incredible work in his field, but also because he does a lot of work that may be a little bit outside of what you would think an oncologist does on a day-to-day kind of basis. Is does a lot of work in drug access work. So maybe we can start off there, Paul. First is maybe you can tell people, like, why is that even important? Why should people care about drug access?
Well, I mean, the bottom line, Lester, is there's no point in having a good drug that treats lung cancer if you can't take it. I mean, it's really as simple as that. And when COVID hit, if you remember all of the talk about vaccines and the rapid development of vaccines. And then the whole conversation for the next sort of year was, well, how do you actually get people vaccinated? And it's kind of the same thing actually, what's interesting? If you were to put into ChatGPT, which cancer has made the biggest advances over the last quarter century, it will answer lung cancer, and it will answer. We tried this last week. It was fun. And it will say very eloquently, it's lung cancer has made the biggest advance because of three things: lung cancer screening, immunotherapy, and targeted therapies. So immunotherapies and targeted therapies, we see new indications, new drugs coming out, all the time. But that's no good unless they're available. And in our Canadian healthcare system, that means being available in all provinces and territories and publicly reimbursed.
Perfect. No, absolutely. And a lot of that, I think that sometimes people forget that just because a drug is developed, that some people have to be able to access it, right? And then you did a actually very interesting piece in Current Oncology. Yes, I think it was 2022. So it's two years now from there, where you had a full, basically full edition that was purely on drug access, right?
Right. Yeah.
Do you mind kind of like walking us through why was that necessary? Like, why did you kind of feel like you needed to go down that route with you and your colleagues? No, it wasn't just yourself. I know you had a lot of colleagues that participated.
No, but there's a good story to that, I guess. Well, I say it's a good story. It's a good story if you're interested in it. If you were to go into a medical school class and say, well, today we're going to talk about drug access, they'll be asleep. It's a dry topic, but it's so important. So I got involved in this field in general through working with Lung Cancer Canada. Initially, I was recruited by Dr. Natasha Lale. She'd be great to have on your podcast if she's not already been on. She's sort of, one of our leading lung cancer oncologists in the country. You've had Natasha on.
So she recommended us to reach out to you, actually.
Oh, there you go. It's a small community. So Natasha was president of Lung Cancer Canada, and she recruited me, and I joined the medical advisory committee, and then I became chair of the MAC, and then I took over from Natasha, and now the excellent Dr. Stephanie Snow is president, and Ros Juergens in Hamilton took over the chair of the MAC. So I get to be past president, which is all the fun stuff. You do kind of do the things you want to do without a lot of the governance stuff. But through the Medical Advisory Committee at Lung Cancer Canada, we are a community of lung cancer specialists across the country, not just medical oncologists, radiation oncologists, thoracic surgeons, pathologists, radiologists, respirologists, and we provide clinician input into files that are seeking public reimbursement in the Canadian system. So we've been doing this for 10 years plus. Every time a company comes with a new drug and they want to submit it through the processes, then as a community of physicians, we look at that file, and then if we want to support it, then we combine and we write to whichever agency it might be. Maybe we'll get onto the complexity of all the different steps that a drug process has to go through. So I had a fairly decent working knowledge of the system. But then as I kind of went on in my career, it was really apparent that, the vast majority of my colleagues really didn't have a good working knowledge of it because it's so complicated. And then 2020, I was due to take a sabbatical. So I thought, this would be a good sabbatical project. And then that got deferred, of course, because of COVID. So it happened in 2021. I had this grand idea, guys, that I was going to work in the mornings, and I was going to go for a run. I was going to go play golf. I was going to do some cooking. And the first month of my actual sabbatical in 2021 we were back in lockdown. So everyone was home. The kids were home. It was a disaster. But anyway, I took this opportunity to, I was invited to guest edit an issue of Current Oncology, which is a sort of primary, it's an international journal, but it's really caters well to the Canadian oncology scene. And so I guest edited this issue, and the topic I chose was access to cancer drugs in Canada. So I was involved with writing a few of the pieces for that, just kind of more overseeing the process. And then we had contributions from all sorts of people around the use of real-world evidence, or conditional funding agreements, or outcome-based agreements, and or what happens if there are delays in access, and lots of sort of contributions to this. So that's kind of how I got involved in it. But what that special issue showed, I think, was that we do live in a pretty complex system relative to some other countries that seem to be able to do it, not easily, because I think it's complex decisions everywhere, but a little bit more streamlined.
So from your perspective, what were really the big takeaways in terms of the obstacles? Is it just the complexity? Is it specific components of the system that are really the obstacles? Where can we maybe target our efforts?
Well, we can probably target them at many levels, but essentially, I think you can think of this as maybe 4 or 5 steps from a drug going from discovery, if you like, to being, if you like, bench to bedside would be the kind of phrase. So from discovery to actually bedside. By that, I'm going to mean being publicly reimbursed in every province and territory. So firstly, of course, we learn that there's a new drug and that it's positive and that it works. And so, for example, I just recently was at the World Conference on Lung Cancer in early September. And the first clinical trial result in the main plenary session was a new drug. It's called ivonescimab for what it's worth, but let's just call it drug A. And it turns out that drug A is better than drug B. It's basically a a novel type of immunotherapy, which also targets tumor blood vessel growth. So for a tumor to grow, it has to kind of recruit its own blood vessels. So this is a drug which targets it uses sort of a traditional immunotherapy approach plus this, we call it angiogenesis approach. Anyway, turns out if you put those two together in one drug, it was better than immunotherapy. So that's stage one. We learn at a conference, oh, look, there's a really strong positive trial. This is a drug that we think we might want. Now, it turns out for that particular drug, there's some other trials happening we'll have to wait for, but in principle, clinical trial first. It's like, okay, so we want this drug. The pharmaceutical company makes it. They obviously have their positive trial. They want to market their drug. So the first thing they'll do is they'll apply to Health Canada. And Health Canada will issue what's called an NOC, or Notice of Compliance. And that is basically an assessment of the drug, which says, yes, this drug works. 2, it's safe. So yes, you can have this drug in the Canadian market, and it's assigned what's called a DIN, a drug identification number. So from that moment, in theory, I can prescribe the drug. The problem is no one yet is going to pay for it. So Health Canada is the first step. Health Canada is maybe not the biggest obstacle. They work to pretty clear timelines. It's a bit more transparent. There are some issues sometimes. We want them to do what's called an expedited review and go faster, and they won't. We sort of argue back and forth if we think there's a real unmet need. But that's the first step. Health Canada's actually got a thing called Project Orbis. If you've heard of this, it's basically the Canadian system, US, a few other countries, I think Singapore, maybe Australia, UK, maybe have the countries wrong, but something like that. And basically it means that if one country does the work, the other countries can kind of piggyback onto it to make it faster. So in theory, that sounds great. Oh, we're going to get regulatory approval faster. But all it does is it gets us maybe Health Canada a bit faster, but it doesn't. We need all of the other steps. So step 1, like a successful drug, like from a clinical trial. Step 2, Health Canada. Step 3 is the health technology assessment process. So that's gone through various names. Back in the day, it was JODA, the Joint Oncology Drug Review. Then it became PCODA, the Pan-Canadian Oncology Drug Review. And then it became the CDA, the Common Drug Review Pathway. And in the middle it was CADA, the Canadian Agency for Drugs and Therapeutics and Health. So it's gone through all of these different versions, but essentially does the same thing. In Quebec, it's NS that does the same thing. Mm-hmm. So health technology is where now we're saying, okay, you've got a drug, it's effective, it's safe, but do we want it in Canada? Do we want this in our formulary? Does this add value for patients? Is it any better than what we're already doing, or is it just because of just another option? So that's a process where we get to provide clinicians input, patients get to provide input to that. And you need to get a positive recommendation there to move to the next step. So if you get a positive recommendation there, then, okay, so that's now step 3 done. That's positive because mostly if you get through steps 1, 2, and 3, you're ultimately going to make it to market. But there are examples where it doesn't happen because of step 4, which is then, okay, there's a drug, it's licensed in Canada, we've decided that we would like it from the HTA. Now, number 4, can we afford it? And so that's the PCPA. There's a test at the end of this, by the way, guys. PCPA, the Pan Canadian Pharmaceutical Alliance. So that's confidential. We never know the results of this. It's all behind closed doors. It doesn't work to any particular timeline. This is definitely an area where we could intervene a bit and say we'd like some more transparency and we'd like some set timelines. The website is a bit better than it used to be. It can tell you if a drug there's been an application and whether it's sort of in the queue or whether it's undergoing negotiations or whether there's an LOI and a letter of intent issued at the end of it, successful or unsuccessful. So that's where the negotiations happen. And basically what they're trying to do is they're trying to negotiate the provinces. So the provinces all sit on PCPA and they take turns as a province being the lead negotiator, and they're trying to negotiate a discount. So if like a lot of the oral therapies for lung cancer now, as a ballpark, their list price is around $10,000 a month. I think it's crazy expensive. Now some are less, some are a bit more, but it's a ballpark. So PCPA is negotiating a discount, and we don't exactly know how much that discount is. We get a sense it's around 80%, maybe more, based on some of the comments that are now being put in the health technology assessment recommendations. So, we recommend that you fund this, provided it's cost effective, and we recommend like an 80% reduction or whatever. So it has to go through PCPA, and there are some really disappointing examples in lung cancer where this has failed. So in particular, there's a combination of drugs for a rare subtype called BRAF lung cancer, where there's two drugs called dabrafenib and trametinib, and the company were unable to negotiate a price for lung cancer patients with this BRAF lung cancer. What was particularly galling is that they did successfully negotiate a price for BRAF subtype of melanoma, same drugs, different cancer. And so it left us at Lung Cancer Canada just fuming, angry, mad, upset, frustrated. We wrote to PCPA and we said, we think that you're penalizing lung cancer patients. It's just another example of stigma against lung cancer patients. And the response we got was, we can't discuss the negotiations. They're all confidential. So, and so, look, it's difficult to know. It's easy for me to sit here and throw PCPA under the bus here, but there's two parties to that negotiation. The drug companies there as well, and we just don't know. But what we do know is that if you've got a BRAF subtype of lung cancer right now in Canada, you don't have access to these drugs unless you've got private insurance to pay for them. So I'm almost there. This is a long monologue. That's step 4, the price negotiation. If that's successful and the price is negotiated, then it goes back to the provinces, and the final step is then each province has to make a final decision about, okay, does the negotiated price fit within their provincial budget? And it should do, because they've negotiated it as a group of provinces. But what we do find is that provinces finally list the drug on their formulary at different rates. So some it'll be pretty much immediate, some it might take months and months and months. And you get a sense that there's sort of internal work that each province has to do, and some of them sort of are doing it in parallel with PCPA, anticipating the result, and others maybe wait till the end. But this all comes down ultimately to patients' lives. And one of my colleagues, Dr. Penny Bradbury, who's our kind of Canadian lung cancer research lead at the Canadian Cancer Trials Group, she and I wrote to the Ontario province, I guess a couple of years ago now, when immunotherapy was approved for mesothelioma, so rare type of cancer of the lining of the lung related to asbestos exposure. And immunotherapy actually can make a big difference. And it went through all of these processes: positive trial, Health Canada, PCPA, and INS and the HTA process, then PCPA. And then Ontario, they do list it now, but it seemed to us at the time it was taking months and months and months. And we were getting patients saying, so there you go. So where can we intervene? Certainly HTA could be a little bit quicker, and they're a bit inconsistent. You get a recommendation for one file and you think you're going to get one for the next, and somehow it doesn't. PCPA for sure, we could intervene, and then maybe some uniformity about provinces implementing. There's another opportunity.
Yeah, death by 1,000 cuts. It sounds.
No kidding.
Yeah.
No kidding. I gave a presentation once. Sorry.
No, go ahead.
Here. I gave a presentation to at CAMO, which is our Canadian Association of Medical Oncologists meeting. This is probably about 18 months ago now, and they asked me to talk about physicians' as advocates and how you can get involved. And I guess I was in a funny mood at the time when I was preparing my talk, because I was a bit fed up with regular talks. So I put up TV shows and movies for all of my slides, and each TV show or movie was meant to illustrate a point. And I don't know if you've seen the Squid Game, but the Squid Game was the slide I put up as my example of this process, because you can, in the Squid Game, for those who haven't watched it, you start with, like, I don't know, 100 people, and they go through these versions of children's games, but you die. Like, if you don't pass the test, you die, and then one person's left living and wins the prize and the money. And I kind of made that comparison, that the process is, you can die at Health Canada, you can die at PCPA, you can die at the HTA process, you can die at the provinces, and we've got examples of all of them. So yeah, it's a bit like the Squid Game.
Yeah, no, it's this for this podcast, we've actually delved into this process a couple of times, and actually we had a poll that we actually put out on LinkedIn a couple of months ago, just to see, like, if people could get the order right, like what was necessary. And I think actually, well, it's kind of a biased audience, so the people tend to be quite educated in this matter that were answered the poll, right? So quite a few people were able to get the answer right. But I think it does surprise a lot of people, especially a lot of my friends in the US, who think, oh, you're a single payer system, right? That should be super easy, right? And they don't understand that, oh, there's actually this many steps, arguably even somewhat more complicated than, say, the US, because in the US, actually, the vast majority of cancer patients actually are really funded through Medicare, right? The insurance that pays for it is usually through Medicare. So for them, they just go through basically just Medicare, and that's like 60% of the population.
And Lester, Medicare and Medicaid, unless this has changed, as soon as the FDA issue an approval for a drug, Medicare and Medicaid will pick it up. So it's very quick. In the UK, the HTA, or Health Technology Assessment Body, is nice, and their recommendations are binding. So the cost negotiation goes along with it. And so it is frustrating to have all of the steps in Canada. And at the minimum, it might make sense to say, why don't you put the HTA process together with PCPA? And so if our health technology assessment body is going to recommend approval of a drug, then we know that we're then going to get it. And that the funding is, negotiations are sort of built into that. And I think we will probably accept that. And I think also, while I'm a lung cancer oncologist, and I might say, look, I want every lung cancer drug available, I want all of the options to sit down with my patients to talk about. Of course, I want all of those options. But we're not immune to the world around us. And we can all see, we're in 2024. We're talking about, like, cost of living crisis and inflation, and then we look in healthcare, and we see all of the other needs in Canadian healthcare right now, whether it's a shortage of family doctors, or it's pediatric mental health, or it's elderly care needs. We're not immune to the fact that everything's got to be paid for, and so we can't necessarily get all the toys, but it would be nice to be a little quicker, a little bit more predictable, for us and for companies as well, so we can, so we're not sort of left hanging, we're not left angry when there's sort of an injustice that we perceive. So yeah, it's frustrating. But as somebody said to me once when I was getting into the advocacy world, and actually I put up a TV show for this as well in my talk, but it was a show called Lagan. I don't know if any of you have seen that. It's a Bollywood movie about cricket. And the movie itself is about 4 hours long. And cricket is a game that, in its best format, takes 5 days. But so I was talking about, when you're in advocacy and we're working for these changes, we are in for the long game here. We're playing the long game. We're not going to get discouraged by one setback. Yeah. But we just got to keep plugging away.
That seems a very, very appropriate movie to for you to focus on, given your back. Yeah, I assume you're from the UK, right? You had to choose something that was both Bollywood and cricket, right? So
yeah, well, it's interesting. So I've got this audience in front of me. I'm showing these TV shows, and I kind of put up a show, and I'll say, "Well, who knows this one?" And a lot of people go, "Oh, yeah, that's Toy Story," and common one. And then there'd be some kind of more eclectic ones that maybe one person in the room would get. And then I put up Lagan, thinking that maybe no one or one or two people would get that, but actually half the audience put their hand up. But I guess it's that sort of South Asian diaspora in Canada. It's required viewing, it seems.
So Paul, let me throw this out there. I know you do a lot of real world evidence research, and oftentimes and similarly with us, that's a center of our focus. Do you think to use a show CSI, do we think that that's one of the pieces that is missing in accelerating some of these negotiations? Is the data, whether it's Canadian data or comparative data, or what I've heard sometimes is, well, even if we have comparative trials, it's not the right comparator because that's not what's used in Canada. Is data one of the pieces of the puzzle to accelerating access in Canada?
Costas, I say yes and no. For some situations, yes. For others, probably not. If you look at all of these bodies now, Health Canada, CADF or the CDA, if you look internationally, the FDA, EMA, European Medicines Agency, NICE, they all have policies now on utilizing real-world data, RWD, or real-world evidence, RWE, in their assessments and their HTA assessments. The place that it's used, I think, depends a little bit on the application. So if we're in a sort of a common lung cancer situation where there are thousands of patients and there are big randomized trials, then RWE probably doesn't have that much of a role in those initial processes that we went through earlier, from Health Canada to HTA and beyond, because there is enough sort of traditionally accepted robust data. Where real world evidence, I think, really does play a role in this situation is in these rarer subtypes of lung cancer, and there are more and more and more of these. And this is sort of applicable beyond lung cancer to other rarer diseases. But so, for example, in lung cancer now, ROS1 lung cancer, ROS1, is a rare subtype. It typically occurs in people who've not been exposed to tobacco. It maybe makes up 1% of people with lung cancer. The BRAF example that I mentioned earlier, again, it's about 1% of lung cancer patients. So, we're talking about clinical trials, internationally run clinical trials that maybe have 40 or 50 people, 70 or 80 people in. They're not randomized, they're single-arm studies, but they show really clear effectiveness of the drug. And our HTA bodies, to their credit, I think that they're trying to, get their handle on this. But historically, they were not equipped to deal with non-standard data. They were only equipped to deal with randomized trials. And I used to have this sort of image in my mind of an old mainframe computer with steam coming out of it, like can't compute, and it's just because they just didn't know how to deal with it. But now I think they're learning that, and they've learned that quite effectively. So there's a really rare cancer called NTRK, NTRK, or NTRK fusions, and it's an example of what we call a tumor agnostic alteration, because it can occur across different types of cancer. So there are some pediatric cancers where it's really common, like a rare cancer, but the NTRK is found in almost all of the cases. Or a really common cancer like lung cancer, but the NTRK subtype is actually 0.2% of lung cancer. So it's vanishingly rare. So in the big trials of these cases, there were like 12 lung cancer patients in the whole trial. But the drug worked in all of them. So they've had to learn how to address these. And then if we can provide real world evidence data of, well, what happens through patients who either have this type of lung cancer but don't get these drugs because they've not been available, and we can show maybe how other drugs are ineffective or marginally effective, or we can show real world evidence maybe from other jurisdictions or from our jurisdictions of patients who have been able to receive these drugs through compassionate access programs, through private insurance, then I think those really are helpful. What's unclear is how much weight any panel would look at it when they look at the submitted trial data and then real world evidence data. We don't really get a sense of where is the weighting, but it is being used.
Do you think another area, actually, I'm asking this question because it's somewhat of a loaded question, primarily because you already talked about it in your special issue. So I know you're on board with this idea around leveraging maybe real world data in OBAs, which is outcome-based agreements, really almost like something gets approved, or maybe conditionally, or whatever the mechanism may be, and then subsequently you measure the effectiveness of it in the real world, and in that way it almost de-risks it for the insurer in a certain sense, right? Is that an area that you've kind of looked more deeply into as well?
Yeah, so not in my personal research, but we can kind of talk about those. There are two separate issues that you mentioned there. So there's conditional funding models and outcomes-based agreements. So conditional funding models is the idea that we're going to say, okay, look, we've got these 5 steps to go through: Health Canada, HTA, BCPA, the provinces. As soon as Health Canada issues a DIN, a drug identification number, and approves the drug, then automatically the drug's going to get funded. It's conditional. It will get funded until those other processes have played out. And if PCPA ultimately says, no, we're not going to negotiate a price, or before then the HTA process says, no, we don't want this in the formulary, then the conditional funding stops and we're not going to have that drug in Canada. But that's a way of meaning, well, it means a number of things. It means that patients who have that disease are not penalized when there's an effective drug potentially out there while waiting for this process, which could take 2-3 years in some cases. Secondly, it allows real-world evidence to be gathered through that time. So there is a thing at Health Canada when they issue their approvals, this NOC letter, Notice of Compliance. There is another version of it called an NOCC, a Notice of Compliance with Conditions, which is, yes, you can market this drug in Canada, but within 3 years, 4 years, you need to provide us with this additional data, whether it's another trial or safety data or something. And so the conditional funding model would be a sort of an HTA approval with conditions, if you like we will fund this drug on condition that you get through A, B, and C. OBAs, outcomes-based agreements, are a little different. We've been kind of talking about wanting to see this happen for, I feel, for years. There are sort of murmurings that provinces are looking for novel approaches to drug funding. CADF, or now CDA, talk about also looking for novel approaches. So an outcomes-based agreement would be the idea of saying, okay, Lester, you've got this particular type of cancer and there's a new drug and it's really expensive and we don't know if it's going to work with you or not. So here's the deal. The drug company, we'll call them pharma, is going to pay for the drug for you for the first 3 months, say 2 months, 3 months. So no cost to the public payer. But after 2 or 3 months, we need to do some scans. There need to be some assessments to say, okay, is this drug working for you or not? If it's not working for you, well, you don't want to carry it on, because why would you want to be on a drug that's not working? I don't want to prescribe it to you, because why do I want to prescribe a drug that's not working and maybe causing some side effects? So we'll stop and we'll try something else. And the public payer is off the hook. They've not paid a cent out of taxpayer dollars for that. The company has taken all of the hit, if you like. But if after 2 or 3 months, oh boy, you feel great, the cancer's shrinking, no side effects or minimal side effects, you're doing well, we do some scans, everything's looking good, so we're going to carry on, then the government can say, okay, well, we'll take on the payment now. So the government has the benefit of knowing they're only paying for a drug that's working. You're getting the drug you need. I feel satisfied as a physician because I'm giving you a satisfactory treatment. The company's now happy because they're now getting paid for their drug. So these OBAs, they intuitively just make sense, don't they?
Yes.
At least when I explain it like that, I feel like, why don't we do this? But we don't do it. And we've asked and we suggested to various companies with particularly with drugs where there's like a 50-50 chance of it working. If it's a drug where it's 90% likely to work, then you might say, come on, government, just pay for this. This is a like historically successful drug.
Yeah.
But if it's a lower chance, it just seems to make sense. But I don't know why PCPA haven't jumped on this, or maybe they are and we don't know about it, and they're looking at this with some files. And maybe you know of a file where this is happening. To my knowledge, this has not yet happened in certainly in cancer care. I don't know of any examples.
Yeah, no, it's very, no, I was just going to ask, like, what do you think's causing that barrier? But it seems like it's a little bit, this lack of transparency is one part that we keep on getting back to, that you feel in some ways, if there was more transparency, it would be, at least you would know, right? You know where the barriers are, right? Even if the barriers are very, very insurmountable, at least you would know like what the barrier is, which could be like, we're willing to only pay like $1 for this, right? And and the pharma whatever says, no, that's ridiculous, right? At least you would know that would be the issue, right?
At least you'd know. And maybe, we've also talked about this idea of having a sort of sliding scale, if you like, but there'd be a published sliding scale. So by that, I mean, let's say there's a drug which we're going to give in the adjuvant setting, so after surgery maybe, and it's going to really reduce the risk of a recurrence. So it's improving the cure rate. So this is a drug which is the difference between life and death. It means you're going to die in 3 years from a recurrent cancer, or you're going to die at a ripe old age of something else. So you might say, well, okay, that is a high premium. That is a big win. The prize of cure is as big as it gets in oncology. So we'll be prepared to pay more for that. Versus here's a drug where you have a stage 4 cancer, which is ultimately not a curable cancer, and this drug might help you live 3 months longer on average. Now, a lot of people might say, well, boy, if it's only an extra 3 months, thanks, but no thanks. I'm not interested in that as a patient. A number of my patients do tell me that. But a number of my patients say, well, you're telling me that's an average. And I'll say, yeah, that's an average, which means some people don't benefit at all. Other people might get a big, big benefit. But it's still a big, big benefit, isn't a cure. And so you might say, well, look, the benefits are not as big for this drug, so I don't want to pay as much. It's not as big a prize. This is the bronze prize, not the gold prize. So, having a sliding scale might be nice. But you'd need to know up front, and companies would like to know, wouldn't they? Say, "Oh, look, we're coming in with, drug A, which is a cure. Pay me for that. Here's drug C, which is modest benefit. I still like to be able to sell it, but accept that I won't get as much back."
Yeah,
I don't know. I'm not an economist.
No,
Health
that's
economics
a
is
conversation
not my
that
major.
I don't think that they've really want to have. I think yet they're
No.
not ready for that discussion. But you're right. Transparency, I think, is a big piece. And I think if people are concerned that they're taking on too much risk, and I think that's part of the discussion as well. Government doesn't want to be seen as taking on too much risk. Companies don't want to take on too much risk because then they got to explain that to their shareholders. But there has to be some sort of ability to share that risk and maybe take baby steps. Try it and I think that's the intention now. Is let's look at rare diseases where there's less of an impact. So if we goof up and make the wrong decision, it's not a huge financial hit either one way or the other. Whether it's the government that gets it wrong or the company gets it wrong, and learn from that. So I think I'm very hopeful that is what at least happens in the short term, and hopefully it is short term, as opposed to waiting another 5 years before we jump onto what the rest of the world has already started to pilot, whether it's Germany or Italy or the UK. I mean,
Yeah.
there's examples
So
everywhere.
there are certainly examples of conditional funding models. Are there examples of OBAs internationally?
You know what? There's only a few that I've seen in the U.S. But you're right. It's the conditional reimbursement models that I think are the one, which in essence are really the same, right? So we'll fund this, but there's an expectation of additional evidence, and if it's not there, then the funding goes away.
Right. I guess you're right. And that's additional evidence on a macro level, and then an OBA is additional information on a patient by patient level. But I would have thought politically the OBA just makes sense, because as a government you can say to the population of whatever disease it might be, you know what, if this drug works for you, we're going to pay for it. And you can say to the general population, saying we're only paying for drugs if they work. Right. If they don't work, like, the pharmaceutical company's got to take the hit for that. And the pharmaceutical industry, you imagine, would like that because it means they're getting into the market. Maybe there's a carrot for them that if they go down an OBA route, the dollar value that they would get for selling their drug is a little bit higher, because they're taking the hit for all of the first 3 months of treatment for everybody. And so for then those that continue on the drugs it's working, they'll get paid a little bit more for that. I don't know. Like I said, I'm no health economist.
Paul, I think that's some good economics there, Paul. Good economics.
That's Monday morning economics for you, right? No, but I think that's something that's really quite, because we had a chat recently on our last podcast with somebody by the name of Tyler Meredith, and he was the senior economist that advised the Liberal government, at least specifically in this case, the federal government of Canada. He was their economic advisor in the last, I think, 6 budgets or something along those lines. And he actually helped educate us on like how the budget's even put together, right? It's actually quite super esoteric again, and probably would make some of our audience sleep, but it's actually incredibly educational because it's not what you would think, just like what you kind of articulated here as well. One of the things that he mentioned that was a little bit disappointing, might not even be the right word for it. I'm sure your vocabulary is much more robust, Paul, so you can let me know what the right word is. But he mentioned that not that cancer care isn't important, but it is no longer seen as the almost like top healthcare priority, right? That other things have really taken front stage. Specifically, mental health is a very, very, he says, super top of mind. Obviously, addictions to opioids and the fentanyl pandemic, or access to primary physicians, right? That cancer care has somewhat waned because these other issues are maybe gain more speed, more light. But the other component is there's just a thought process that, hey, you know what? Actually, the mortality rate from cancer has actually improved over the last, I forgot how many decades, whatever, 3 decades, 4 decades. So, hey, you know what? Our job done, right? Like we did our job. And he actually said that if the cancer care community wants to shed light on this really important issue, because quite frankly, cancer is still the number 1 killer in Canada. and I think even a lot of the world, right?
Yeah.
That we need to advocate. And I was thinking, like, what could we advocate for? Maybe what, as a community we need to do is really shed light around this process that's super what you say is incredibly bureaucratic, many steps, and on top of it, it's not as transparent as it could be, and hence decisions are made that aren't, like, you don't know what to make of them, right? The decision was made, and then, hey, sorry, Paul, you sent us a letter. It was super well written, but we actually can't tell you because it's confidential.
Yeah,
Right?
well, that was really frustrating. And so I think, as advocates, we need to be smart. We need to ask for something that is important. We need to ask for it in a respectful and reasonable way. We need to, not ask for ridiculous stuff. It has to be reasonable. But then we've got to be savvy, and we've got to say, okay, well, what are the government's priorities? Okay, so how do we phrase what we're asking for to align it with what the government wants to do? And so maybe we'll talk about equity in a bit, but equity is a big buzzword right now in federal and provincial politics. Well, we can definitely leverage that in lung cancer. But just back to what you're saying earlier about, sometimes I think we get frustrated as citizens, maybe, that some of our politicians, our political leaders, some of them are excellent. I think it's very easy to just throw politicians under the bus and say, oh, well, politicians are all just sort of ambitious people after their own, self-aggrandizement or something. But I don't think that's true. I mean, sure, there are some big egos, but generally most politicians that I've met seem to be in it for the right reasons. But there can be a tendency towards populism, and so, all the healthcare resources go to COVID or fentanyl crisis or mental health. Or family, I mentioned earlier, like a shortage of primary care family dogs. So all of those things are important. Of course they are. I'm not denying that. And I'm not trying to say they're more important than cancer. Or less important than cancer either. But sometimes we need a grown-up in the room just to say, this is not sexy. It's not the hot story, but it remains important. It remains common. It remains crucial to most families at some level in Canada. And that's, that half of us will get cancer in our lifetime. Nearly a quarter of us will die of cancer. About 80 to 85,000 people a year die of cancer. A quarter of those are lung cancer. And when we talk about progress, and I talked earlier about, my ChatGPT example of lung cancer having the biggest improvement. So 5-year survivals in lung cancer, great. They've gone from 10% 15 years ago to 22, 23%. They've more than doubled. It's been fantastic advance. But we're wrong-headed if we think that's success, because really what that means is 78% of people with lung cancer are not surviving 5 years. Whereas with prostate cancer, the 5-year survival rates are in the 90s, and breast cancer in the high 80s. So getting lost in my rambling thought here, but
that's exactly what we want.
But I think just to bring it back to kind of a conclusion, we want to say we want our politicians who are on their 4 or 5 year cycles to watch Lagan and play the long game and say, actually, you know what? Cancer's been here for generations. It's going to be here for more generations. So let's put robust infrastructure in place. Let's figure out where the problems are. Let's combine the HTA and the negotiation pricing all together. Let's maybe push that together with Health Canada. I don't know. Maybe make it just a one-stop shop. Let's think outside the box of OBAs, conditional, and let's not just kind of go from, what the story of the week is in health.
Yeah, no, absolutely. And I think we have to kind of bring this topic up, just because today, just for those of you who are maybe our international audience. I don't know how many of there are out there, but today is the day called Truth and Reconciliation, which is a very recent day that was, I think, what was it, last year or the year before? I forgot which year it was actually put together by the federal government, right? Specifically around a lot of the, what's the best way to phrase it? It's around kind of understanding our history and understanding that there were a lot of wrongs that were done to the Indigenous population in Canada, right? And it's kind of to remember that and make sure that we kind of don't fall into that trap. And that's specifically, Paul, you mentioned around equity, right? So maybe we start off first with what is equity to you first? Like, how would you kind of think about this term? And then, moving forward, because I know you have a podcast as well, and that you ran on Lung Cancer Canada, right? And you talked a lot about that, is at least in the clinical trial perspective. Is there, like, what can we do? Because it seems like data seems like an obvious thing that we should that would kind of help in at least understanding what the problems are, right? And then how do you kind of move forward. But like, what to you is equity, and then maybe we take it wherever you would like to go there.
So today, September 30th is, that's right. It's the day when we bring to mind truth and reconciliation, but it really shouldn't be tokenism. I think some people will put on an orange T-shirt like I have, and that's like job done. They're just, but it's not. A couple of weeks ago, the CMA, Canadian Medical Association, issued a formal apology for harms caused to Indigenous peoples over the century of the CMA. They apologize for their role and the role of the medical profession in general as sort of our representatives for past and ongoing harms to First Nations, Inuit, and Métis people, ranging from residential hospitals and abuses and failures that the medical profession has to hold its hand up and be responsible for. With lung cancer specifically, we know that among Inuit patients, and if you go to Nunavut, the Inuit have amongst the highest lung cancer rates anywhere in the world, about 5 times as high as southern Canada. Wow. We know that lung cancer is more common, not so if we get away specifically from Indigenous issues, but we know lung cancer is more common generally in Indigenous populations, but generally in rural populations, in populations with lower socioeconomic groups. And those can overlap, not always, but they can. So in those rural and lower socioeconomic groups, not only is lung cancer more common, it's also more deadly. So it's more likely to be diagnosed at later stages, and stage for stage outcomes are worse. So we have an equity issue. And we're not unique in that. I think there's lots of data coming out of the US about African American populations in the South and poor outcomes, poor access to clinical trials. But I suspect if you had any sort of open-minded society that looks at its health outcomes in its Indigenous populations, you'll see similar things. I'm not going to name call other countries because I don't know their data, but we just have to put our hands up in Canada and say, there is an issue. Of course, that's the first way to fixing something, is to recognize there's a problem, and then we can actually work towards things. And it might be as simple as things like lung cancer screening, which is just starting to roll out in a number of provinces, but really to say, okay, where do we want to put our screening units? Do we really want them in downtown Ottawa and downtown Toronto? Sure, we do, because they're big population centers. But are they really, do we want them in also access in small town Canada, where the lung cancer rates are higher? And that's probably the answer.
And actually, because I know Ottawa, it's for those of you who are not familiar with kind of geography of Canada, Ottawa is sort of in the south in of Canada, and I believe that a lot of the population, I think Ottawa treats cancer patients that come from one of the territories. I forgot which one is it.
Yeah, from Nunavut. Yeah,
It's from Nunavut. Okay, so from
yeah,
Nunavut, right? So you will probably actually see, and not everyone in Nunavut
yeah.
is Indigenous, but there's probably quite a large Indigenous population that
Well, the majority. Yeah.
the majority that comes down and is treated by yourself and your colleagues, right? Do you find that is it really a like what's the biggest issue? Is it really kind of a geographical issue more so than anything, meaning that they would have to fly down here and or fly down to yourself
Hmm.
and get treatment, or is it something else?
So, Lester, I would suggest that you have another episode of the podcast specifically on this issue, and you don't ask a white English guy to comment, because I think what I'm learning and have learned over the years of being here is that nothing about me without me, and so ask people from the territories, ask people from Indigenous communities about lung cancer. I can tell you just sort of nuts and bolts. Nunavut's got a population of around 35 to 40,000 people. The main hospital is in Iqaluit, in the provincial, so the territorial capital, which has a population of around 8,000. And most of the population of Nunavut is Inuit, and the non-Inuit population is not exclusively, but largely in Iqaluit. Iqaluit, the Qikiqtani Hospital in Iqaluit has a number of resources, but they're not extensive. They have a CT scan, so we can get scans done there. There's limited access to biopsies. We're just starting to think about cancer treatments in Nunavut. Right now, people come down to Ottawa from eastern Nunavut, come to Ottawa, and then from western Nunavut, Winnipeg or Edmonton. And wouldn't it be nice to have the resources so that people didn't have to be away from their families and their loved ones for so long, to have all of their treatments down here? Now, sometimes, just unrealistic to think that you'd have all of that expertise in a territory the size of Mexico with a population of 35,000, but we could do some things better.
Completely understand. And with that, I don't want to take up too much more of Paul's time. Paul's obviously a very, very busy oncologist. But I think, to wrap it up, maybe summarize a little bit here, through our conversation, it seems like three things that you really emphasize is one, transparency, two, kind of like simplifying the process, and three, really kind of talking to the individuals that directly who have the issues, right? Understanding what really is the big pain for them. So just talking to people, I guess, seems simple enough, right?
Probably in every walk of life, if we all just talk to each other a little bit more. And maybe talk to it without going in with our sort of feet set in position. Go into it with being willing to be persuaded. Then I think we might all just do a little bit better.
Absolutely. I think that seems like some lyrics from a song that you could come up with very, very soon. But with that said, Paul, thanks again. I'm gonna is Twitter or X the easiest place for people to reach you at? You can at least follow Paul at PW or P Wheatley-Price on X. Is there another avenue people can kind of take a look at your work? I know you're at Lung Cancer Canada. People can also always find you there.
So lungcancercanada.ca, you kindly mentioned my podcast there, or the one we do at LCC called Lung Cancer Voices. I have to say, since Elon Musk took over, I've been less active on X and Twitter. So probably Lung Cancer Canada might be the best avenue, and through the pod.
Excellent. Okay, thanks a lot, Paul. Thank you very much for joining us, and thank you everyone for tuning in today. If you have any questions, comments, please comment below, and of course, like and subscribe this podcast as always. Costas, any last thoughts you want to leave on, or have a great day?
I think that we'll wrap it up for today. I was trying to think of a perfect movie or TV show.
Me too. I know.
But I just couldn't do it on the spot. So that we'll say.
Well, if you want the transparency one, if you want the transparency one, look at Slow Horses.
Slow Horses. All right.
That's the homework.
We'll leave on that.
Okay. Thanks a lot again, Paul.
Thanks, Paul.